So my question is your pre-procedural or peri-procedural anticoagulation strategy for patients on DOAC or warfarin and warfarin.
Yeah, so when the patients come to me, they're already on anticoagulation. So whichever anticoagulant they've been prescribed by their cardiologist, I usually do not change it. I leave it on. But because we do same-day discharges. So, because of same-day discharges, if they don't come on any anticoagulation, I usually start a NOAC probably within 2 to 3 weeks post pre-ablation. If there were chats, I did a 38-year-old gentleman last week who was having AFib, and his monitor, he was having 6-second pauses, and he was referred to us for a pacemaker. He's 38, but all his pauses in the monitor, he had not one, he was having 8 to 10 pauses a day, but all of them are post-conversion pauses. So I did an afibrillation in 38 CHAD 0. I usually start them on anticoagulation a couple of weeks before. You don't necessarily have to, because all my patients get a TE on the day of the procedure also to make sure there's nothing going on. But just to be in the and then we send them home the same day. So I reverse the heparin, I give protamine sulfate and I reverse the heparin, and then we pull the sheets out. But then I send them home on a NOAC post-op. If I have to do a heparin, Coumadin, then I have to give them sub-Q heparin and Lovenox and send them home. So I've been using a lot of DOACs currently.
And for the GA option, it's patient preference, or when do you prefer the GA? General anesthesia for the procedure.
So it's physician dependent. I use general anesthesia for 100% of my procedures. But I think if you look at the United States, I think it's 50-50. Some centers have gone down to conscious sedation with just if you do a pulmonary isolation with conscious sedation, you can get away because the procedures it's less than an hour. So after coming here, I'm going to go to try and see if I can do conscious. It's just also the patient comfort is better when you do general anesthesia. But before we used to do Foley catheters, we don't do that anymore. Before I used to put 4 sheets, now I'm down to 2 sheets. I think it's safe to do pulmonary isolation in people with conscious sedation. I just have to change the paradigm.
Your venous closure strategy is compression or venous closure strategy?
So I do figure of 8. My partners do 2 percloses in the veins because of 16 French sheath. They put 2 perclose and close, but I just do figure of 8 on both sides, and then I watch them for 6 hours. But all my AFib ablation patients go home in 6 hours.
It's just a general question. I mean, like sometimes we do see patients with recurrent stroke with dilated LA. We do repeated Holter monitoring, and we are never able to document AF. So is there any point in starting them on embryonic NOAC?
With the left atrial size?
4.5?
No, I mean, unless you have AFib, I mean, even nowadays with the new guidelines, aspirin is also being taken away. So unless you see document AFib, I don't know if maintenance of antiplatelet agents or anticoagulations people with a large left atrium. Now, if I do a flutter ablation in a patient who had a large left atrium, then the question is, post-flutter ablation, we stop anticoagulation. Would you be willing to stop an anticoagulation in a patient with a left atrial size of 5.6 who came with flutter? And that's a question, I think it's user dependent. I've been very generous with ILRs. And so I use a lot of ILRs to monitor. But for a patient, if an isolated left atrium enlargement, I don't even think insurance will pay for an ILR. I don't think we can even use an ILR. We can tell them, look, you have a higher instance of atrial fibrillation, maybe lifestyle modification, use a Fitbit or something if you have AFib, or an Apple Watch. If you do have AFib, you can let us know. But I think current guidelines do not state you need use any anticoagulation in these patients.
So suppose you're doing the pulmonary, we would go from right inferior to right superior. You're doing the right inferior and you had to double tap because of a pulmonary phrenic nerve transient dysfunction. What would you do with the right superior? What is your strategy after that?
It's the same strategy. If it depends on the amplitude, right? So I do a lot of palpation. If your amplitude, like last week, if the amplitude is dropping, then I'll just do a single tap and wait for it to come down, then amplitude comes down. If I lose total isolation of whether superior or inferior, I double tap. So they say that the phrenic nerve palsy happens more with right inferiors, but I've seen it I've seen it both. I can't tell which one, but I'll double tap. It all depends on the amplitude.
Yeah, so what I meant is that once you double tap on the inferior, and what is your strategy after that for the superior?
So if your phrenic nerve isolation and you lose phrenic nerve capture, I wait 15 minutes, 20 minutes, 30 minutes. If after 20, 30 minutes, if the vein doesn't come back, I hesitate to give a lesion in the right superior, but also I know that if you had it in the right inferior, very unlikely that you have it in both veins. But by guidelines, you cannot ablate on the right side unless you have phrenic nerve. But in my there was only one patient that the pulmonary vein did not come back in 30 minutes. Within 10-15 minutes, you'll start seeing a little bit of twitches. And the other thing I've done is I'll put the phrenic nerve, I'll put the achieve catheter right superior, and I'll pace at 20 volts from the achieve catheter to make sure there is some phrenic nerve captured at that time, and I'll check it that way too. Instead of pacing only from the right superior, I'll put the achieve in the phrenic nerve and pace from there also. So to be adjunctive, because if you're pacing at 20 volts from the achieve, the phrenic nerve is close by, you will see phrenic nerve stimulation from the achieve catheter also.
So in that case, with the achieve pacing, you will go on...
So if I pace in the right inferior with 20 and you see phrenic nerve pacing, then do the superior first and then go back to the inferior. Then you may want to change the vein you use also. So I use that strategy if I see if I see a 55 kilo or a 60, like a skinnier patient, or I see a vertical heart, or a patient post-cabbage, you could easily go into the inferior veins and pace at 20 quickly to make sure there's no phrenic nerve loss too.
Okay. And have you had any instances where you put an achieve and you've not found signals in any of the veins?
Yeah.
And in that case, what is your cryo time?
Yeah. So that's a very good question. So let me backtrack. So if there are 4 pulmonary veins, the question is how many veins are active and how many veins are quiet. Initially, when we started AFib ablation, they used to say just go and ablate the veins that are active. Now the theory is that you ablate every vein, whether they're silent or active. So in theory, 75% of the veins are usually active, which is 3 out of 4 in patients. So if I see signals, then I use that Ariana strategy where I do time to isolation plus 120 seconds. If I don't, with the new achieve balloon, I give 180 second lesion and then I wait for time to 0. By the time it turns time to 0, if you're greater than 10 seconds time to 0 and you don't see signals, success rate is almost 99%. But in them, invariably, I'll also give a second lesion. So I'll do 180 plus 120. I don't do single shot in those patients.
So everybody gets a 3 plus 2, 180 plus 120.
If I don't see signals, yeah. If I see signals, then I have time to isolation plus 120.
And what are the strategies to manage pulmonary vein stenosis? You said you have 0,
Yeah.
but what are the current strategies to manage pulmonary vein stenosis if it happens actually?
I don't know. I haven't done it in 15 years. I haven't had any. But if the patients do come short of breath, we will. You can get a CT scan to see if there's any pulmonary vein stenosis. Usually it's a 25% reduction in pulmonary veins. Then there are strategies that you can inflate. You can you can open up but I'll leave that to the interventional guys because we haven't seen any in 15 years. I have to re-look at what the strategies are, but I'm not very sure. So, but most of them are usually asymptomatic if I'm not wrong. So.
Just one quick question. So the 90-day blanking period was something that was based from, I think you showed from 2012. So as our energy changes, like we've gone from RF to cryo, do you think we should revisit this 90-day blanking period? Is it since the mechanism of tissue injury is changing with all of these different energies?
No, that's a good question. That should we reissue 90 days? I don't know how the 90-day number came. I don't think anybody is familiar. Basically, we used the 90-day because we felt that left ventricular cardiomyopathy takes 90 days to heal. So we presume if that's 90 days, then left atrial myopathy to heal also takes 90 days. But there's no real data. If you look at the left ventricle, it's an easy story. I mean, usually the data basically says that left ventricular remodeling happens in 42 days, right? And there were a bunch of EPs sitting in Italy somewhere drinking wine, and they said 42 days is very hard, just make it a round number, let's double it and make it 90. There was no real 90 days, also a very number that just pulled up after 4 glasses of wine. The actual left ventricular remodeling is only 42 days. But so I think the 90-day blanking is just it's a historical number. It makes sense because they will, even when you ablate, there's going to be some inflammation. Give it some time, but also it also gives us expectations for the patient. If I tell you in 30 days you'll be free from AFib, and the patient comes back on day 31, it kind of, so 90 days is a nice time to, keep everybody happy. But I don't think that number is an arbitrary number. It's just a made-up number. So.
Thank you, sir. If there are no more questions, then we'll break for lunch.
Thank you.
Just for a break. One more question, sir. This OSA sleep study. Now the 7th year we are conducting it. I think the awareness is going up because there's a lot of discussion interaction among doctors about the sleep study. Now I just want to ask the panelist, what's the difficulty you face here in asking for a sleep study? Practical difficulty, because I had the interaction during the tea interval. The doctors face difficulty in asking for a sleep study. Can you enlighten us?
Sir, one thing we commonly face is the stigma associated with suggesting CPAP. So we say after sleep study, if you're having an OSA, then we may suggest a CPAP. I mean, once they come to know what is a CPAP and you have to put some kind of a machine on your face, the stigma is more, and the patients are really not willing to undergo the study for the fear of using some kind of machine during sleep.
But you can ask for a sleep study, Would you predict that we have to have a CPAP and all? You can just like that.
We do suggest, sir. I mean,
actually, we don't have any problem in suggesting a CPAP. It is the hesitancy from the patient side to accept that they have to go through a sleep study is a problem, first. Second thing, even if you prescribe a BiPAP machine, CPAP machine for them to use, they feel uncomfortable to use it. Now that the automatic BiPAP machines have come, even then, initial days they feel hesitancy, and some people lose hope after a couple of days and then they stop using it. So, but once they start using it for 5 days, 7 days or 10 days, then they start realizing the benefits of the CPAP machine, and then they continue to use it. But from the physician side, I don't think there is any hesitancy in asking for a sleep study for any suspected patient of an OSA. In fact, in my practice, any obese patient with a history of snoring and daytime somnolence or tiredness, we straight away counsel them for a CPAP study, sleep study.
Dr. Bedi, one question. How often you come across surprising anatomical anomaly during the procedure of?
That's the reason I do a TE on every patient pre-op, because a couple of times I started doing the procedure without a TE, and I noticed that on the echo they called it mild MR. And then when I did a TE, or they call aortic root is not dilated. And then when I put the ice catheter up, I can't even see the septum because the aorta is so big. So then to mitigate that, I've been doing a TE on every procedure. So I've picked up severe MRs, I've picked up people who had aortic root dilatation by TEs, because a lot of times when the patient come to us and they have AFib and they've seen the cardiologist maybe a year before, we have not repeated any testing. So just to be to the great equalizer, do a TE like a day before or a week before to make sure there is nothing. I've also seen left atrial appendage clots. I've also seen no left atrial appendage, despite nobody reported it. So most of the time I will find severe MR. If I find severe MR, then I'll refer them for MVR plus MACE procedure or something like that.
Lawrence, can you add up to how often you come across anatomical anomaly during this procedure?
See, the one thing is, because we are starting up the program, all of my patients undergo CT for now. So everybody undergoes CT heart. So we have a system to merge this left atrial anatomy into the map. So I do this for all my patients to start with, all the 12 patients. So we have what we are dealing with. Like yesterday's case, we know that before starting itself, patient has only 3 pulmonary veins in one and 5 pulmonary veins in one. So we can pre-plan that. I think once we go further, I think all this reduction in pre-investigations can be done. But unlike what they face in US, we don't have that typical insurance related issues. If I want a CT, if the patient is willing, I can do. So, and our investigations are much cheaper. We can get a CT done in hardly 2,000-3,000 rupees. So if it helps us to make a better decision making, I think I prefer to do. So we pick up a lot of things.
That's for Dr. Triple to know that we are having a better score there in States.
I think with this we'll close the discussion, and